Okay, we have, can people hear me in the back? Good. Okay, so we have first question. Does RRMS change to progressive MS after 20 years? Great question. The answer is yes or no. There, a lot of the kind of big cohort studies that looked at kind of where people ended up after 5, 10, 15, 20 years, many of them were done in the era before we had our current disease modifying therapies. And also, some of them might have looked at things like harder endpoints like an EDSS of 6, needing a cane to walk rather than like transition from relapsing to secondary progressive MS per se. As I was kind of trying to get at in my talk, that is a little bit of a squishier, thing. It's not like there's a bright line that tells us like, okay, yep, this person's now secondary progressive, especially given that what we're now realizing that PIRA can happen in relapsing remitting MS as well as secondary progressive MS. So it almost kind of begs the question, like, why do we even still use these, terms? Why do we still have these distinctions? But I would say that, in more recent studies to look at kind of, the evolution of MS over time suggests that we are delaying, if not completely stopping progression, especially with use of early use of disease modifying therapy and use of highly effective therapies. So yeah, I don't know that I would necessarily say 20 years, but yeah, historically that's been, some of the, you've seen like 15 to 20 years between diagnosis and like EDSS of 6.
So I have a set of questions on brain volume and spinning off a little bit from the talk we just did. I'm hoping that I answered some of these for these people in the presentation itself, but just to ensure. So one of the questions was, how do you know what a healthy brain volume is? How do you determine that, and what do the percentiles mean? So as I mentioned, there's different softwares that are used to try to take those 2D slices and try to estimate the 3D volume from them. A lot of those software companies have done MRIs on like bunches of people and kind of know like what sort of medical diseases those people may have had. And so you get a sense of like, just if you took 100 people, off the street, like what would be the usual brain volumes and what's the range of brain volumes, because everyone's brain is different. I memorized all those. It's fine. I'll get them later. Thank you. Try not to lose them a second time. So when you have that, you have a range of what the brain volume is, and we can use that and compare against that to say, okay, well, compared to 100 other people, there would be 5 people who have a lower brain volume than you, and that'd be the 5th percentile. So you never go to 0%. Like you're never the lowest person ever. You're never at 100%. You're never the highest person ever, but you're somewhere there in the middle. And again, for an individual, that sometimes doesn't mean as much. If you're at a lower level starting out, we'll probably talk about the immune therapies that we know help with brain volume as well, just to help protect that as much as we can. But kind of longer term predictions from that, it's more difficult. So if you're interested in kind of knowing those results and you don't see those in your reports, like that's things we may have access to, so you can ask us at the next visit. But know that we may not be changing treatments just based off of that. There's a lot of those other factors. What do we see as far as MRI lesions? What do we see as disability or progressive symptoms? And what are we seeing as relapses? Those are some of the things that we use more often to make those decisions.
Yeah, it's not all about the size, it's what you do with it, right? How can we improve memory and cognitive skills? So Dr. Kammeyer had a lot about this in his talk. There's, right, eating a healthy diet, staying active mentally, reading, social engagements, going to the library, going to the museum, all that stuff. How much more likely are people with MS to get dementia or Alzheimer's disease? Well, that's a great question. So cognitive symptoms are very common in MS, but rarely does it progress to kind of frank dementia. Dementia being when somebody has cognitive impairment to the extent that they are not able to care for themselves. The most common reason for that in this country, I think actually the world, is Alzheimer's disease. There's not really a clear link between MS and Alzheimer's disease. They're really kind of separate entities. So if somebody, comes to me and they're having cognitive symptoms, and those cognitive symptoms are very like out of proportion to what I'm seeing with the rest of the picture, and especially if it's getting progressively worse over time, the cognitive part, not the physical part, then I'm going to start to think harder about, could there be something else going on? Could this be the beginnings of this other process, Alzheimer's disease, in which case I might recommend, some additional investigation.
Yeah. And just to go off of that some too, there have been some studies that for people who have MS, like there can be a higher risk for dementia. And so, we can think of it a little bit in terms of cognitive reserve too. If you have MS, if that's, causing, some more wearing on your cognitive reserve, from brain volume or lesions or inflammation, like that can make it a little bit easier to have those dementia in the future. There's, as Dr. Gross was saying, sometimes if it seems kind of very significant for what we would expect for someone with MS, like the cognitive symptoms, we do have neuropsychological testing, which is kind of like the full, usually 4 to 8 hours of cognitive tests that looks at like every specific part of how you think. Sometimes that can be helpful, especially there's certain patterns with Alzheimer's and other dementias that can kind of help us see that as a higher diagnosis. Sometimes that kind of also can give ideas of, what are strengths or weaknesses for an individual. It's not something that we do for everyone, but sometimes that's testing that we can do and can be helpful. For some people who have, symptoms of, thinking slower or kind of more difficulties with their memory, especially if they're noticing it at work. Sometimes we'll recommend something called cognitive rehabilitation, which is usually done through the speech therapists here. And they just sit with you and kind of go through like what are the specific symptoms that you're noticing and work with you to figure out ways to address those and kind of in a functional and useful way for your daily life. So I found that to be helpful for some people. And sometimes that can help more with daily life than some of the broader cognitive testing too. So again, if you're noticing kind of big difficulties with that, especially in your work or your daily life, like let us know at one of our visits and we can talk through like what are ways we can address that.
Next question.
Yeah.
Yeah. Okay. So what are the comorbidities associated with MS, and at what stage can they be expected to appear? We have a related question. Have we found a connection from other autoimmune disorders and MS? So comorbidities, just for those who don't know, that's just like other medical conditions that can potentially have an impact on a person's course. And so there have been studies that looked at this and have found increase in certain comorbidities in people with MS, things like mental health disorders, depression, anxiety, cardiovascular problems, cerebrovascular, so like strokes, things like that, sleep disorders, restless leg syndrome, obstructive sleep apnea being very common, lung problems, COPD, asthma, things like that. Some of these can, of course, have an impact on the course of MS, and so you want to make sure that those are being appropriately addressed either by your neurologist or by the appropriate specialist. It's also, to some extent, you want to try to figure out, is it connected to the MS? Is it connected to maybe one of the MS treatments? So, for instance, some of our DMTs, they could have certain medical conditions as a side effect. So, trying to establish whether that's what's going on. And then, as far as the autoimmune piece, yeah, I mean, there's kind of a shared genetic predisposition for several autoimmune processes, including MS, inflammatory bowel disease, type 1 diabetes, thyroid. So stuff like that, you can sometimes see, and certain studies have shown more, higher prevalence in people with MS and also in the family members of people with MS. You might see like mom with lupus and, dad with psoriatic arthritis, and then, you have MS kind of thing. So we try to ask about that kind of thing at your initial visit, at least.
So we had a question from online on what vitamins should I take to slow brain atrophy? And so this is a great question. I didn't go into great detail on vitamins in my talk. Right now, there's not any that are recommended. So if you look online, you'll see that there have been studies, again, more in the dementia realm of studies and Alzheimer's realms of study that we're looking at like omega-3s, folic acid, various B vitamins, and some studies that show that they might be helpful, but there haven't been any big studies to show that those are helpful. The Alzheimer's Association, I think, has some of the best information on brain atrophy and brain volume and dementia, and they fully kind of look and don't have any recommendations for that. Like there's not enough information for them to start to recommend it. So it's not something that I've started recommending for my patients. Is not something I take or recommend to my family. Knowing and having read through these studies, the exercise, diet, avoiding smoking, avoiding alcohol. Those are some of the things that we know much more can be related than the vitamins. And so those are the things that we kind of focus the most time talking on. And you've probably had us harp on at some of the visits with us. Those are tougher to do, but they pay off the most in the long run.
Yeah, we just I had on one of my slides the potential neuroprotective agents, including lipoic acid. We just finished up the LAP MS study, our participation in it, and the results were negative in that it didn't actually show any benefit in any like physical or cognitive dimension, but some there was some data to suggest that it did slow the rates of atrophy in people with secondary progressive MS. And that was kind of a similar finding to what was seen in the earlier trial. So that actually may be a real finding. It's not something that I'm necessarily going to recommend to everybody because, again, it didn't really seem to, produce any tangible physical or cognitive benefit in people. There were also some side effects identified during the trial, including involving the kidneys. So it would be something that, if you wanted to talk about more, at a visit, be happy to talk about it. But yeah, so we're still trying to find that one thing that'll really help with, preservation of nervous system tissue. Okay, let me go on to the next one. What are the different types of specialists involved in MS care in addition to neurologists? So several. So we will also sometimes have people see a neuro-ophthalmologist, and we have one, Dr. Bennett, that works closely with us. Rheumatology can sometimes be helpful, especially if the person has a comorbid rheumatologic condition, lupus, rheumatoid arthritis, that kind of thing. Psychiatry, neuropsychology, we use them a lot. Different rehab providers, physiatrists, physical therapists, occupational therapists, speech therapists, urology for people who have, bladder symptoms. This is not somebody you would necessarily see, but you might read the reports of neuroradiologists, and we work closely with them. And so, yeah, so there's a lot of different providers that may be involved in your care that, kind of help us get this kind of multidisciplinary approach that we value in our clinic.
So there were a few questions on what's the relationship of MS and neuropathy, and then what are some of the treatments for helping with neuropathy and alternatives to gabapentin, which is one of the treatments. So when we talk about neuropathy just means kind of any dysfunction of the nerves. And usually when we talk about it, we're talking about a sensory neuropathy. So some symptoms of that can be numbness. For some people, that can be intense kind of burning pains. And for some people, that can be like itching and kind of other very sensitive to touch on the skin. So it can show up in a few different ways for different people. For MS, it can kind of happen in a couple different ways. So you can have numbness or burning pains related to your MS lesions. So if one of those lesions is in one of the set of nerves that goes down to a part of your body and like is in charge of sensation for that area, you can have neuropathy and neuropathy symptoms from that. It's also common to have neuropathy outside of MS. And so that's a little bit of a different kind of neuropathy. It's from the nerves that have already left the spine and are just traveling through your muscles, your tissues to your skin. That type of neuropathy is most common to have in your legs. And it can happen for a number of different reasons: diabetes, alcohol,
Certain production of proteins like
yeah.
in the family of multiple myeloma, like
Yeah, I was
kind of
going to
thing.
say there's some kind of, if your blood vessels are not working as well, sometimes that can also kind of cause neuropathy
Autoimmune
symptoms.
problems. Yeah.
Yeah, so there's a number of different causes for that type of neuropathy. And so if you're having those types of symptoms in clinic, like we might be looking at it from a few different ways. If it, seems to fit with one of the areas that we know has been affected before with your MS, like it might be related to that. If it's that more kind of broad, leg and gradually kind of creeping up your leg type neuropathy, then we might be looking for some of those other causes too. And that's important because the treatments can be different. For the peripheral neuropathy, the kind that's not related to MS, some of the treatments are, figuring out which of those different things might be related, and then trying to work to control that disease. So for people who have diabetes and their blood glucose levels are too high, we might be working to say like, okay, is there a way that we can narrow or improve control of that with your primary care doctor? Some of the different treatments for that, kind of either way, that we can use for the symptoms, especially that painful neuropathy, depends a little bit on how far those symptoms go. So if they're in just like a very small spot, sometimes it makes the most sense to try a topical cream. And I've had people try a few different things with success. There's over the counters for lidocaine cream or lidocaine patches that can help, especially with like small painful areas. There is some capsaicin cream, which is a cream made from like chili peppers that can cause like a burning sensation that feels good to some people. I haven't had many people like trying that, but it is one of the things that we know can be helpful. And then I've had some people try like CBD creams too, and tell me that that was helpful for them, knowing that some of those cost more. The For people who have kind of more widespread neuropathy, it might be across like a few different areas or across like a larger part of their leg. Sometimes we'll try medicines by mouth to help with the neuropathy. A lot of these medicines are not ones that you take and then it is helping immediately, but something that you take on a regular basis, and it helps to rebalance the signals so that you have less of that pain. So gabapentin is one of the most common ones for that. It's one of the ones that has the least number of side effects, so it tends to be one of the ones that we start most often. A similar version of that is pregabalin or Lyrica that you may have heard of. There's other medicines like amitriptyline or certain antidepressant or anti-anxiety medicines that will sometimes also use depending on what else is going on in the person's life. Some of those we can use to help with headaches too. Some of those help a little bit with sleep. Some of them help with mood. And so depending on what's going on, like we might use all of those, or might talk about all of those.
It's like more like jabs of pain, paroxysmal. You might do like oxcarbazepine or
Mhm.
carbamazepine, which is also there's a good segue here to my question. Do you believe or think that functional medicine will help or impact MS? So I guess it depends a little bit on how we define functional medicine, but it does. It's not all about necessarily pills and Western medicine and whatnot. There's also, of course, non-pharmacological stuff. There's massage, acupuncture. I think certainly I've had patients tell me that they do those things and it's helpful to them. Dry needling is another one that people have found to be helpful. So I like to use the term more rather than like alternative, treatment, more like complementary. So I'm like very fine if you are doing these things. It's not harming you. It might be helping you. Great, as long as it's not like to the detriment or exclusively that and not doing the things that we're also recommending like disease modifying therapies. So yeah, I'm all for it.
Yeah, I agree with that. I think there's a lot of things that we don't have big studies for, but there's a lot of things that you've probably read online that have helped different individuals, and everyone's an individual. Their symptoms of MS and what works best for them is individual for them. And so, in general, if there's something that we don't have great data on, but it's doesn't seem too risky, you can ask us about that. If it's not costing a ton of money and it's something that you want to try to see if it helps, like I think that's fine to do. Just keep us in the loop for that too, just so we can talk about the risks and make sure it's not something that
Yeah, like
we
bee stings we would not recommend. Don't do that. um but yeah,
that's been studied.
yeah, no, it actually has been studied, and people were used to be very into that. I also don't recommend like intentionally ingesting a lot of parasites. It's not a plan for success. Um, any,
I,
go ahead.
I can go on.
Okay.
That was a good ending though for that.
I bring it up because it's out there.
Yeah,
People have done
yeah.
these things.
There's been a lot of
Yeah.
different treatments and theories over the years, and so if any of those come up and you're like that
Mm.
it seems a little bit out there, but someone said it worked for them online, like let us know. Like we
Yeah.
can tell you
Yeah, I
what
mean, we learn a lot from you, from I tried this thing and it was helpful kind of thing. Like that actually is a real thing, and that's what gives us ideas for like maybe more studies.
Mhm.
Um,
So there was a question on, is it bad to start and stop MS meds for vaccines and for like other reasons? I think this is a great question because, there's been some outbreaks of vaccine preventable diseases recently. And while they haven't gotten too big, like that's still a potential risk for the future. And obviously COVID a few years ago, like there was a lot of discussion on this too. So there's for the medicines that we have, like the Copaxone is one of our therapies that doesn't directly decrease the immune system. So, in theory, vaccine should work similar with that. For most of the other medicines we have, like they do something to change how the immune system works, and that's how it's helping with the MS. It's trying to decrease and prevent that over inflammation that shouldn't be there and is cycling and causing the MS. So for most of the vaccines, we know that there's been studies with the COVID vaccines and with flu vaccines, especially. We know that you still make a response to those vaccines. It's not as strong as it might be otherwise, but you still make a response. So we do still recommend, getting a lot of the usual vaccines, like the ones that you would normally be recommended to get otherwise. The Sometimes we will talk about like different strategies for that, like using a flu vaccine that has a few more strains in it, or sometimes doing like a second dose. There's different strategies that sometimes we'll talk about or try. The We're usually not stopping immune therapies to do those vaccines. There's some of our immune therapies that it can be dangerous to stop quickly. So Tysabri, natalizumab, that's one of those, fingolimod and similar medicines to that. If you stop those quickly, sometimes you can have a rebound of MS activity, and sometimes that can be more severe than kind of what you started with. So, we definitely don't stop those quickly. For some people, if they really, really need a vaccine for whatever reason, like one of the live vaccines, those are few and far between, but the MMR, some of the varicella, so not like Shingrix, but some of the like ones that you get more often as kids, um, those you really can't have while you're on immune therapy. And sometimes if it's like a CD20 medicine, like rituximab or Kesimpta or ocrelizumab, we might allow that to kind of wear off, like see that, okay, your immune system's back, and then we might be able to do those vaccines. Again, those are usually on a case by case basis. It's usually, you know, the risk of not having the vaccine is starting to outweigh the risk of the MS relapse. So, if you're needing that, if you're needing one of those live vaccines, like talk to us, like let us know. We'll try to help you figure out like the risks, benefits, and the timing for those. But that's come up for me, especially recently with some people doing travel to places where there's yellow fever and other things that need certain vaccines.
Yeah.
What's that?
Oh, we don't think that Copaxone has a significant impact on vaccine function.
The others can. The Copaxone's probably the one that wouldn't.
Yeah, but for medicines, like Dr. Kammeyer said, like, B cell depleting therapy, ocrelizumab, ublituximab, that kind of thing, they're given intermittently. And so if, we often recommend people time their vaccinations such that they're kind of farther away from their last infusion. And that way they're more likely to have a more robust response. But even still, if, it's probably better to get it than not to get it if we're talking about like the flu vaccine or whatnot. But the question here is also, this person is 61, worried about infections. So, I mean, this is a topic near and dear to my heart. This idea of like, when is it safe and appropriate to like stop MS medications or, de-escalate MS medications? If we're talking about an infusion, is it okay to extend the interval between the infusions? And in many cases that is okay. So I've been talking to a lot more people lately about that concept and, giving the immune system a little bit more breathing room, a little bit more of a chance to recover, so that maybe you're not getting sick all the time, or so you don't have to worry about that as much. Do we have time for one more? Or yeah, okay. Let's see, what can we do? Okay, if I had to choose the number one lifestyle change that most benefits patients with MS, what would it be? Well, that's tough. I mean, honestly, they're all important. Eating a healthy, balanced diet, getting regular physical activity, keeping your mind, your brain, active and limber. Those are all important. I mean, if I'm talking to somebody, in the office, I might try to identify the one that the lowest hanging fruit first, one that I think it would be the easiest to accomplish, or maybe that's the most urgent for that particular person at that particular time. We might just kind of try to, work on that one at that visit, and then we kind of come back and we see how that one's going, and then maybe we pick another one and target that one. Behavior change is hard. It's one of the hardest things that we have to do as doctors, is to try to influence people's day-to-day behavior, and especially it's challenging when we're talking about things like cigarettes that are very addictive or whatever, long ingrained habits that we're trying to break. That can be a challenge for you and for us. But yeah, I mean, I think trying to work on what we think we can make progress on, and get you to a better kind of place holistically, I think is part of our job. Yeah. I believe that's it for time. Thank you very much for coming. Thank you for your questions.